Afternoon. Welcome to the Wednesday, November 1st, 2023 regular meeting of the Board of County Commissioners. If you look on agendas, you'll find the November agenda today actually listed in October agendas. So if there's any confusion there, we're still in October, Captain Riley. Is that okay with you? Okay, so we have a good meeting today, Ms. Morgraisi. We have a discussion on Lane County Stabilization Center. And we have a good panel with us. So, Mr. Morgraisi, if I may, turn it to you to introduce your panel and start the discussion.
Thank you, Chair. I don't want to steal any of the thunder from the folks who put a lot of time and effort into the discussion today. I think the thing maybe just to help frame a little bit of the conversation, we've talked for many years. I know the board knows that we've talked about the need for a behavioral health stabilization center in our community. And in the last several months to year or two, I'd say, there's been a lot of conversation about siting of said facility. The potential of purchasing a building or building something new on county-owned property, or purchasing some private property. And what we wanted to do today was take a step back and really talk less specifically about the physical structure of a stabilization center and more about how this critical operation fits within a broader system of care in the community. It's a very timely discussion because of announcements and planned actions by Peace Health and changes to the emergency department and impacts on the behavioral health unit that the hospital runs and how that is part of this overall system. So just want to encourage that sort of for all of us to step back from some of the particular discussion around this as a project and as a capital project and talk and encourage more of a discussion about the broader behavioral health system that we're trying to build out and create. So I'll turn it over to Eve Gray, and you may want to do introductions, or at least as people go around and speak, introduce themselves.
Sure. So thank you all for this extended time today to be able to talk about the Stabilization Center. And I am happy to just point out the folks who are here so that everyone's aware. And you'll notice that we really very purposefully wanted to make sure that behavioral health and public safety partners are here together to be talking with you about what the Stabilization Center will do and also what the Stabilization Center won't do, as it is part of a system of care. Brittany DeLiso, who is our very capable Stabilization Center project manager, will be leading the show most of the day today. But feel free to pepper in commentary as we go and questions. I think this will work best as a dialogue rather than holding questions until the end. We have, for those of you who have not met him, Dr. David Ritu is our medical director for psychiatry and is a child and adolescent psychiatrist. So in particular, if you have any questions that are specific to youth, he is an incredible expert. Marcus Vehar, I think you all know as our county counsel, and the others on the table, we all know each other, but in case anyone watching doesn't, D.A. Perlow, Captain Riley, who runs the jail, Greg Rickoff over Community Justice and Rehabilitation Services, and Sheriff Harold are here. Dr. Pauline Gashohi is joining us remotely and will be available as well to answer questions.
Awesome. Well, we'll get started. We wanted to start, although I appreciated the framework of thinking of this conceptually, we do want to start with a brief project update also, just because it's been a while since we've been with you all. So we've had this graphic of the timeline in front of you before, and just to highlight what we have done since we have seen you last, which I think was in June, if I had that down correctly. So a couple pieces to highlight. Really, it's been work done in the community engagement area, some work around funding, and then project management and operational as far as our kind of plan to pursue a provider. So starting with community engagement over the summer, since a lot of the big decision pieces were moving a little bit more slowly, I wanted to take advantage of that time since we had it to really turn out to our community and engage ongoing conversation and dialogue and identify opportunities for their feedback that could ideally truly inform the work. So we crafted a survey that we went out. I want to clarify, because people hear surveys and often are like, oh, surveys are the worst, but we actually really were intentional about this being the surveys highlighting aspects of the project that the decisions for those questions would be held off on until we heard back from our community. So this was not a checking the box just to say we're going to, seek community engagement so we can say that we did, but this was actually soliciting input to inform our decision making on the project where we could from our community members. So some of the topics referenced in that survey were around treatment planning, where folks would anticipate, how they would anticipate accessing the program, referral sources, how we would accommodate pets and animals, building design and some of those pieces. And just as a report out, we still are, we spent about 5 hours analyzing the survey results with our equity team. It's one of the pilot projects for the Equity Lens Toolkit. I'm not sure if Latife has brought that to you all yet. So with that lens, we were able to parse out that out of the 547 total responses, 373 of those people were folks with lived experience, either within the criminal justice system, the behavioral health system, or being unhoused. And then we could actually parse out the responses from those with lived experience to really ensure that individuals who often are, their voices are more marginalized had an equal say as they participated in some of this decision-making input. We also did identify folks, or they self-identified, I should say, as being a part of a systemically marginalized community based on their race or their gender, and got to evaluate their responses in a different light in light of that. So really proud of that work, and then closing the feedback loop to go back to the community around some of the decisions their input will inform. Also regarding funding, I think the main movement since we saw you last was receiving $5 million from state legislature. I don't believe that happened yet last time we saw you. So we're at 14.5 million total towards capital. And that, if you all remember the capital estimate, it's at about 28 million. So working our way there, and that's for the full build project. And then lastly, as far as work happening in kind of operational planning and development, a lot of that will be reflected in today's conversation as we're unpacking the model and how it sits within the larger system. But also to know that we did launch an RFP for the service provider. We'll be coming back to you with some more details around that and pursuing decision-making there. And then we are hosting ongoing conversation and dialogue with Oregon Health Authority and DHS to understand licensing and current allowances and restrictions around the model we're trying to pursue, which we'll talk to you all about that as well.
And I think it's reasonable for us to point out that we have set 2025 as the end of this timeline for quite some time now, and 2025 seemed farther away several years ago. And looking now where we are and some of the items that we will bring to you today in terms of the help we need from the OHA on the regulatory side in order to make it legal for us to operate the type of facility we want to operate, the assistance that we need on the financial side, both from capital as well as operating deficits, which we've talked to you about. These are pretty big barriers for us to overcome, and building a facility of this size, even if we were to look at renovating a facility, it takes time. So 2025 is, I think, very optimistic. As we are talking about the provider that we will select, we are going to look at one option that could fast track a portion of this model, and we will also talk to you about the risks associated with making that decision. So that will be for a later meeting for us, so within the next few weeks, I think, but just wanted to call that out because this timeline is feeling really aggressive at this moment, given the barriers that we are facing.
All right, so this is a slide that we've brought to you before. We wanted to bring it back just to ground what we hope for today's conversation. So just as a refresher, really looking at what's in blue as kind of the model that we're all familiar with for more medical or other crises response in the community. Someone calls 911, a first responder comes to the scene, typically law enforcement or an EMT. They are transported, if needed, to the emergency department and set up with ongoing medical care. So what could be comparable, and it doesn't have to be linear, but just as an example, someone contacting 988 or one of the other, we have many behavioral health crisis lines in Lane County, linking up with mobile crisis, such as Western Lane Mobile Crisis that we have in operation, or Cahoots, and we'll touch a little bit more on mobile crisis expansion that's in the works as well. And then getting transported to the stabilization center if needed, and then connected with ongoing behavioral health care. So again, the disclaimer, it's probably never going to be this linear, but this is just a picture of how it can compare to the current system and process in place, and wanting to remind you all that the stabilization center is one piece of this much broader crisis system effort, and many aspects of that crisis system are in flux or expansion all at the same time. Many of which has the same crew of us kind of working on those in parallel efforts and trying to do so in an aligned fashion. So there could be more arrows drawn from the emergency department to the stabilization center and back and forth as human beings are complex people, and we would navigate that, but just wanting to kind of get grounded in this picture. And to reiterate that this is the gold line at the bottom is the SAMHSA national best practice as far as the components of the crisis system and how they might function together. So to reiterate kind of where and how we're being guided in that work. So to go a little bit deeper, I'll read off those tiny words to y'all if we need to with specifics here, but this is calling out, so if we looked at that more linear model, these are the more specific Lane County-based providers of many of those services. And there are a few added pieces to what really makes up the crisis continuum in Lane County. So the top three, the call lines, the mobile crisis, mobile outreach, crisis response, and 24/7 care, those kind of mirror what was in gold in the previous slide. So the people to call, the people to go, and then the place to take them to. And so to highlight, as I mentioned, we have multiple crisis lines currently in place in Lane County, and we have 988 operated by Lines for Life. For you all to know, we are just now solidifying MOUs between Lines for Life and our local county folks, including the 911 Central Lane Dispatch and the other two PSAPs, I believe is the right acronym. I'm learning a lot about the really complex dispatch system that exists in our community. And then also getting 988 Lines for Life linked up with our other walk-in crisis and mobile crisis teams. So that leg of the continuum, despite 988 being around for a year and a half or so now, is really becoming tangible here in our Lane County community. In addition to that, mobile crisis, as you all likely know, we've been commissioned by OHA as the county to ensure that every county resident has access to mobile crisis services, that the whole region is covered, and that's actually done by January of 2024, which, spoiler alert, is probably not going to, we're not going to achieve that. So we're talking to OHA about this. I'm looking up at the screen at Pauline, too, who can chime in at any point on this piece, but we do have efforts right now for Lane County to move forward in staffing the teams to cover the remaining areas. So currently we do have Eugene Springfield covered with Cahoots, and then Western Lane County, including Deadwood, Mapleton, Dune City, and others covered by the Western Lane County Crisis Response Team. And then we don't really have coverage for adults anywhere else in Lane County at this time. So we're doing some parallel efforts of standing up, what it will take to staff that with county staff and all the behind the scenes HR and union related work for that. In addition to soliciting input and feedback from our rural partners in each of the other pockets we hope to serve. Because this is starting from scratch, we have a blank slate, we can actually hopefully cater those services to each unique need, recognizing that there are subcultures within each of our rural populations throughout Lane County. So how can we link up with the leaders in each of those areas and really align the services uniquely to those unique communities? I just met with many folks from the Sheriff's Department this morning who are currently really doing this work essentially in a lot of our rural communities, and was asking them, tell me what's working, what's hard, what do we need to know as mental health folks as we try to partner with you in this space. So we just wanted to do kind of a parallel update on that piece because that's a part of the continuum that will really make the Stabilization Center successful, and is also part of the complex and nuanced work that our team is leaning into for our community. Other pieces to add on the bottom half. So again, the burgundy is kind of representing Stabilization Center once we have 24/7 access to care. Of course, we have the hospital and emergency room. And to highlight that a lot of our intended vision as far as scope and capacity for the Stabilization Center was crafted with Peace Health present in the way that we've known them. So we are kind of holding space for how we may need to adjust that work, and removed the Sacred Heart University District from our little grid here and responding to that. And recognizing that the jail does play a role in providing services to individuals navigating behavioral health crises as well. I think some of more of what we'll get to talk about today is where and how each of these spaces work to actually meet the needs of our community members, how accountability plays in while honoring and respecting somebody's needs related to their mental health. And then lastly, walk-in services. So that includes Hourglass, Buckley Detox, brand new Looking Glass Peer Shelter that just opened this last month on MLK property. And then many of our outpatient clinics have crisis walk-in hours associated. And we will take some time, I keep saying this, but later on today to also specifically kind of break down the difference between Stabilization Center and Hourglass a little bit further, because that question continues to come up with good reason. I'm actually looking at my notes, so I'm circling back mobile crisis really quick just to mention we do have full county coverage for youth, and that's through Riverview Center for Growth is their new name, formerly the Child Center. But you know, there's some limitations in length of time for them to get out to the more rural partners because they're not located throughout, but they do have capacity to serve our whole region. So we're learning from them and what they've discovered as well. Yeah.
No, go ahead.
I'm just curious, having just been at the opening or the not groundbreaking for the Cottage Grove FQHC, does that in any way help fill a missing piece in for rural access?
Certainly, it provides the primary care portion of access where we can get someone started with their behavioral health assessment with an integrated behavioral health provider, can prescribe basic medications for less complex challenges in terms of behavioral health conditions. So it's the primary care piece of that.
So no crisis services there?
That's
walking
correct.
crisis. Okay, thank you.
And just as a point of order, if questions come up as your presentation goes on, you're okay with questions in the middle? Okay. So.
Thank you.
And don't look to me for a cue, just look to commissioners for their hands up.
And maybe we should pause now. And any other questions about this as a model and how each of the pieces fits together? Because even with the addition of the top part of this model, we still need the bottom part of the model. The addition of one does not eliminate the need for the others as it relates to individuals who experience behavioral health challenges. And so I just wanted to make sure that if there are any questions about that, or if we should engage further, or if our public safety partners would like to talk about their perspectives on this, we certainly want to hold space. Yeah.
This is not a direct question right now, but just something to think about. We have existing services. And can we talk about the confidence in the continuation of existing services while we talk about adding new services? No need to respond at that point, but just keep that nuance or that reflection in mind.
That is a loaded question.
Well, you know, that's why I'm leaving it hanging.
I just have a little point of order as well. When you decide to use abbreviations or acronyms, spell it out so the public can know what we're talking about, please.
Yes.
Thank you.
That being me, by the way.
So the only other thing I don't see, and maybe, I don't see our parole and probation on here, and yet that is often a place where people both enter and exit these services. Is that just maybe something to consider adding to the visual, or is there a reason that we don't consider that part of the system?
I think that's a great call out.
Great, thank you.
Along with reentry services, which kind of go hand in
But
hand.
particularly because they do street outreach and they're actively engaged with folks who are somewhere else on here. Great.
And I think we could probably broaden that the bottom circle to be more of the public safety system.
Okay, moving on. I actually waited for, Pauline had to step off for a minute, right in time for the slide she was going to speak to, so that was perfect timing. And I will do my best, and this actually speaks a little bit. Oh,
really
she
is
came
perfect
back. Did you hear me?
I was actually just stepping out, but I can do this slide and step away. I'm going to pick up my kid from school, but I can do this and then switch to phone. It's perfect timing. So again, to kind of get us grounded. So this is where our local behavioral health system is. So and we wanted to kind of put these to kind of layer it with where the stabilization center fits in and kind of looking at what is existing and how it would complement some of these systems. So at the very top, we have the state, and I would also say that with what we have currently in the system, it's not working as it's supposed to be. So we all know that the Oregon State Hospital really has not had access to services for a number of years now. So we can hardly get anybody who is civilly committed to the state hospital. It's become really mostly forensics, especially for the 370. That's the majority of the people that are being served at the state hospital now. So it's really limited access. I actually had somebody describe the state hospital as constipated right now, which is interesting description, but that is truly what it is. It's really hard to get people who need that service into the state hospital, although it is part of that continuum, and there's a place for all these systems that we've been talking about. So the other one is the Peace Health Behavioral Health Unit. So that's mostly where our civilly committed people are sitting. And again, ideally, it's supposed to be short-term stay to where for people who are needing longer-term stabilization, either moving to another facility, which in our case, if we had a stabilization center, would be a stabilization center, or if they were needing higher level, then they would be moving to the state hospital. And unfortunately, our current state is people are really staying at the BHU for much longer than they need to be because there's really no other place for them to go. So system-wide, we also have our residential services. So that is after people have stabilized from a crisis or after their hospital stay, they are going into residential treatment facilities. And we also have lost a number of those residential services. We should be in a place where we are building more, not losing residential. And in the last few years, we've lost more than we've gained in the system. So that is also a continuum that we need to be expanding. And while there were some registrative investments into residential, it's still not enough for the need that we're seeing in our community. The other part of that health system is the local emergency department with the hold rooms. That's where the assessments are happening and where mostly we are studying a civil commitment process. So it's again going to be a big gap when we don't have that service in our community. So when we're looking at the stabilization center, it was with all these systems in place. So as Eve had alluded to before, it was not going to be replacing any of these services currently in place. So if one gets moved or eliminated, it does impact how the work of the stabilization center is going to be, or how successful the stabilization center would be. The other part of that is walk-in, so outpatient clinics, outreach services. That's also part of that continuum. People are going to different services depending on the need. So in terms of the stabilization center, I think of it as an urgent walk-in, urgent, I equate it to urgent care in the physical health, that they could start there and then get triaged or moved to whatever level of care that they are needing. But the stabilization center would never be a replacement for the state hospital. It would not be a replacement for the inpatient behavioral health unit that beds that we have at Peace Health, and it's not also not residential. So it would not be replacing any of our residential mental health system that is longer term, or people are staying in residential longer term. And I think Brittany had mentioned there's questions coming up often, like how is this going to be different from Hourglass? And the difference, as we were envisioning the stabilization center, is so the Hourglass, it is the same level of care, but in terms of size, it was very illuminating for me when I toured that facility, and it's very small for one. When we think about what the vision for the stabilization center, it's open space where you have line of sight. You can monitor and kind of be able to anticipate what's going to be happening in that space. With Hourglass, it's very small. It almost feels like there's not enough room to maneuver. In terms of ages served, they're limited to who they can serve. So it doesn't serve the larger majority of people we would like to serve. The locations in terms of drop off for law enforcement is also limited. We've been thinking about a Sallyport that is conducive, it's quick for law enforcement. Well, there is some of that. It's not to the degree that we would like to see happen. So it functions in some way as a drop off, but it's not for example, for the acuity, some of the acuity that we are talking about, and also because of the staffing levels, it's small, staffing levels are limited, so they have to be mindful about people that they are taking on site. So in terms of services too, it's limited in terms of medications, ability to prescribe medications, whereas the stabilization center we're talking about will be staffed to be able to prescribe. And Hourglass has not really used the ability to use a director's custody to move people to as needed to a higher level of care. And they also don't have the ability to move people to a higher level of care. The system is not built currently in a way that Hourglass would be able to move somebody that they don't believe can be served well in their facility. So that the visioning for the stabilization center is to enhance all these limitations that we saw in the Hourglass facility. It is complex, and I want to mention here too that other counties that are trying to do this work too are finding it to be pretty complex. So I'm glad that we're having regular conversations about what it is, what it's not, what's going to serve, who is not going to serve. And I know Marion County is delaying their work for a year. The Gorge had envisioned something similar to what we are doing, but they also had to pull back. And I believe that is on pause as well. So it's challenging. We are not the only entity that's finding this to be significantly difficult to figure out and sort out, because it's the system the way it is currently. It's such a need. There's so many needs in various different areas that to meet every single need in a stabilization center is not really going to be realistic. And I'll stop there and see if there's any questions on that.
Can I add a couple quick points?
Please, thank you, Pauline. Doctor, go ahead, please.
Explain. One is the difference of the ability to prescribe medicines on site may not sound like a big difference, but it really, I think, will translate into a very big difference about who you can serve and how much you can do on the spot. So I just wanted to highlight that. And then in regard to the slide, I just want to also point out that that's a slide for adult services. So if we're talking about youth, the green line disappears and the blue line basically disappears.
Thank you. And Dr. Joshi, do you have time for a couple of questions?
I do.
Then we'll keep it short. Commissioner Lovell?
Yeah, to David, across the table from me, what's the prohibitive barrier for someone like Hourglass to prescribe prescriptions? Is that something the county can fix?
I think a lot of it has to do with staffing, and maybe licensure, but I'm not sure what they're licensed as.
So it's not an insurmountable barrier, is what I'm hearing.
I wouldn't think so.
Okay, thank you.
Thank you. Further questions for Dr. Shohi? Pauline, thank you very much. And thanks for staying. Will you be coming back to the meeting or gone for the rest?
Yeah, I'm actually just going to switch to phone. So I will still be in attendance, but I would be off camera.
Thank you for staying with us.
Thank you. Just a couple last few details to mention too. Part of what Pauline was describing with Hourglass is the lack of ability to transition to a higher level of care. So that's not only about transport, but that's actually on site. So that again speaks to part of the model. So the portion of the stabilization center that would look similar to Hourglass, the kind of open concept recliner space, part of how that works is having on-site individual bedded rooms, so that if somebody is escalating or higher acuity, the stabilization center can still receive and serve them. They would just transfer them to a slightly higher level of care. And Hourglass would have to engage the emergency room, possibly partner with guest house. They do have the guest house as well through Columbia Care that's not co-located. So there's some transport issues and some other requirements with criteria for guest house. So I just wanted to call that distinction out as well. And a little bit more detail on speaking to other counties, because the point of this slide was to say, here's our current reality that we're trying to build this within. So as Pauline mentioned, Marion County has something similar already in place. They're working to relocate, and that renovation timeline was just bumped back a whole year, I assume related to funding and some other pieces. Pauline, can you mute? There she goes. Okay, and then with the work in the gorge, they actually had a provider on board and had worked for the last year plus with that provider, both pursuing funding together, and that provider pulled out. So that was kind of circling back to square one for them. And then lastly, Deschutes County, which we like to highlight a lot of what's happening in Deschutes, some pretty meaningful work. And they're looking at another funding cliff come this June, because so much of their operations are funded by grants. So we just wanted to paint the picture. We're meeting with other counties monthly. The work that we're trying to do is really complex, and there's a reason why it's taking a minute to get it done.
Yeah, and I think, go ahead.
Actually, just a quick question regarding that. The three that we're talking about are experiencing sustainability issues. Is that safe to say on all three?
Kind of all for three different reasons.
Exactly, but
Yeah.
just to put it into a single
Yeah.
sentence. And Marion County is still operating at a good level, but they're waiting to relocate.
To a much larger facility, yeah. Cool.
And I would also say that every stabilization center that, aside from ours, that has been conceptualized in the state has been a significantly lower level of care than the one that we are envisioning. And so when we talk about Hourglass and why can they not engage in director's custody, well, they can't put hands on somebody who is seriously escalated. Why is that? It's because they're an outpatient facility, and today the rules don't let them. And today the rules don't let us. So you will hear Marcus will begin to go through some of the rules and regulations that we're taking a look at collaboratively with OHA. And I say collaboratively in earnest. I know that sometimes we are frustrated with our partners at the state, but I really do think that the folks who are working on the rules for stabilization centers want to see this work. And it's really, really complex. So we're not, our systems are not set up to let people move in and out fluidly through the different levels of care that we want to provide. Today, the rules would have us walk someone out the front door of one of our programs and walk them in the front door of another program because they're not supposed to be connected by sky bridges. They're not supposed to share walls. I mean, this is the level of detail that we are down to in the discussions about what it is that we need from a regulatory framework. So even if we had everything else in place, let's say we had all the money in the world, someone showered it down upon us, we still couldn't open the facility that we want to open because we have to have the rewrites to those rules. And OHA is working on that, and we don't have a clear timeline for when that will be achieved. So I think that's an important piece as well, and an important limitation that we are facing and that others have faced in trying to provide similar services.
And if I may, we do have the jail captain here with us today, and I think it's safe to say that we do have a stabilization center, and it is behind the walls of the jail, and that's not what it's intended to be, but that's de facto where it is. And as Marcus talks, I'm interested to hear how the rules that are prescribed by law really have to be, how that translates to the real stabilization center that's really occurring down the street.
Get there.
I expect so.
Okay. So I just wanted to kind of revisit some of the model. We've brought this to you before, but I wanted to bring more detail and then really hone in on the orange rhombus, maybe? Not sure what shape that is. To highlight some of how this model fits with the system that we've just taken a while to really paint for you. So the intention is that the stabilization center would be accessed through walk-in, drop-off, referral from other agencies, or a step down from the jail or from the hospital, as we've discussed. As a side note, more work that we need to do with Oregon Health Authority is to ensure that we could protect the beds for our Lane County area. Because my understanding, correct me if I'm wrong, but if we accept Medicaid dollars, then the current requirements is that the whole state would have access to those beds, which wouldn't really work for the algorithm that we use to determine capacity, especially if we're wanting to really preserve space to be a discharge option from the jail or higher levels of care, which is certainly part of the plan. Really preserving the trauma-informed care perspective. So much of the feedback we got back on that survey, the community survey, the questions around design and space were like soft lighting and comfort and considering the humane needs of someone navigating a crisis. So however we can preserve that while ensuring safety. And then, as we've mentioned, staffing with peer support, case management, therapists, and prescribers of some kind, and also minimal medical support, navigating the reality of individuals using substances who are presenting as well, and looking for prevention and reduction of behavioral health symptoms as being the primary reason why we're looking to offer services here. So those would be offered within 3 different levels of care. Again, we're taking the time to highlight this for you all to paint the picture of the full model and why the full model matters. So looking at that 23-hour and 59-minute unit, similar to Hourglass as we've just described. So that's where most folks would enter. And then they could, if needed, transfer to the long-term individual beds, which we would have for both youth and adults. And then to note that the youth unit would be intended to, have kind of a shared intake space separate for safety, but folks would come in through the same door and then could get routed to the youth unit where they could stay for 23 hours or they could stay for longer. But however long they stay, they have their own room and space to accommodate other caregivers that may be with them or their own unique needs in safety. And then highlighting, so we've used the term campus of connection with you before, and what that has meant to this point is really highlighting bringing in agencies that we'd be partnering with to come provide actual physical warm handoffs around care coordination, so housing, education, employment, all of those pieces, other mental health providers, those sorts of things. So that's definitely still what we mean when we say that, but I wanted to expand the definition of this campus of connections to also think the campus itself between those three levels of care, highlighting how those units would interact with one another, where someone would enter, possibly escalate and need their own bed, possibly stabilize and move back to the 23-hour unit, really being able to accommodate a range of acuity because we have co-located options right there. Also thinking of a campus of connections, connecting broader to the community and how we partner with law enforcement and understanding the unique role. And we have a whole slide dedicated to that here in a minute, but really understanding if we think about how folks would exit our program, we anticipate either they would need to be transported by law enforcement if there's actual risk of criminal behavior that has escalated to that point, creating space for accountability and safety in that way too, possibly transported by mobile crisis to another facility, or secure transport if they are needing a higher level of care via the hospital, or ideally, and hopefully most of the time, they are successfully stabilized and they're being transported on their own or with a loved one or with an Uber to the next step of their journey. But considering the network that encompasses all of those options, that's all kind of the promotion of a connected community that supports this work. Any questions there? Alrighty, and then we wanted one call out in particular around the youth unit, and it would invite Dr. Ritu to speak to this as well, but not only are we one of the counties that's pursuing kind of the most complex and highest level version of this resource, we're also one of, if not the only, pursuing a space for youth. So some of the other counties are welcoming youth for an initial intake and kind of stabilization and triage within their intake room, which is useful and can help get them to the hospital. But the fact that we're wanting to include an entire youth unit where a youth can come and stay is fairly unique to us, and the bullet points on this slide are why, because it's significantly more complex to include. It's a priority that we cannot and will not ignore in our community, but it takes a little bit more time and strategy to make it work. Part of that is that licensing happens both with Oregon Health Authority and with the Department of Human Services for different aspects of the program. You have to figure out who to speak to in each, and then if they're communicating with one another or not. As Dr. Ritu highlighted, we don't have a behavioral health unit here locally for youth. So if youth are in our unit and they were to escalate and need a hospital level of care, transport and resourcing is going to look different or more complicated for them. We have not received a lot of clarification around the actual physical build and how these services can be co-located with adults. We've kind of tackled that a bit with Oregon Health Authority and with DHS, and there's just room for more conversation there, but it's complex, yeah.
You said these are unique and others are having them, and it sounds like to a great extent that's because of state level regulatory environment, licensure, and those sorts of things. So there are other states that are successfully doing youth services modeled in this way?
I can say that the facility that we toured in Arizona had youth all in one building. I'm not sure if others know, or if Dr. Ritu, if you know about other states doing this work.
I think other states do. There's a lot of variability from state to state. But I am really supportive of continuing this youth aspect to things. In my view, one of the most desperate mental health needs in our community are youth who come in with acute mental health needs. They're suicidal, and they come to an emergency room and they stay in basically an empty room for days, if not weeks, waiting for some bed to open up in Portland if you're lucky. And it's to a point where because I see patients, I'm not just an administrator, and I have families tell me that they don't go to the emergency department, even though they really should, because they don't want their kid to have that experience again. And that puts everyone in a really dangerous spot.
And I think also around your question, Vice Chair, Oregon has a particularly burdensome regulatory environment, more so than many other states that are able to be successful doing this. And it feels like a rule is written for everything and every eventuality, and it means being creative and innovative requires a whole new rule book to be written, as opposed to removing rules that allow us to be innovative and creative while still protecting the people we serve. So that's a significant barrier all across the healthcare system, as well as I would argue that in this particular case, the division between DHS and OHA, Department of Human Services and Oregon Health Authority, is really challenging. And we see this too. If you have a developmental disability, you go to DHS. If you're youth, you go to DHS. If you have a physical health problem, you go to OHA. If you have a behavioral health problem, you go to OHA. If you're an older adult, you go to DHS. And sometimes people are more than that, more than any of those one things. And then they're stuck. And agencies actually fight over whose responsibility it is to take care of somebody, because it's that department or that agency's job. And all of that framework then makes it hard for us to do what's right.
And you're in the middle of that with your son or daughter in crisis who disappears out of your front door and you don't see them again for 2 weeks. Yeah,
Absolutely.
it's terrible for families. You're right.
Yes, it is.
And just to be very clear, they fight in a negative way. It's not for, we want to care for this individual. It's, they're yours, not ours.
Just a quick aside on that, we kind of wring our hands about Oregon, the situation in Oregon, but we should, and really are tasked with trying to get that to change. And you're in a very good position, Director Gray, that you have the ear sometimes of the directors who really have decision-making capability. A lot of it with the legislature, and we know how that operates, but you're in a very good position, Director.
I'm just thinking back, because the OHA hasn't been in existence for really very long in the scheme of things. And it was designed exactly to avoid these kind of challenges and to create sort of a specialty area to help clear the way for better services and better health outcomes. So isn't that interesting? Okay. Thank you.
I'm sorry, my emotion's getting the best of me here, so please excuse this next question. You know, with all these rules, Eve, that you're saying about the rules written for everything and the new rule book needs to be written, Lane County's a home rule charter county. Why can't we just do what's best for our citizens and let chips fall where they're going to fall? I mean, what's the state going to do? I mean, what can we face legally if we decide to do what's right versus what we're hindered by barriers?
So the system is incredibly intertwined in that to accept Medicaid or Medicare funding, we must follow state and federal rules. And to have licensed providers working in the facility, they are also obligated to follow the regulatory rules of their licensing bodies and those at the state level. So as much as it would be wonderful to be able to divorce ourselves, I think both for financial reasons and staffing reasons, I don't know how we would pull that off. And there's also things like with medications, all of that is governed by state and federal rules. So if we're ordering medications and bringing them into a facility, all of those licensures are required. So the system doesn't allow us to operate independently. Unless, Dr. Ratu, you have a good sense of this too.
I mean, I agree with the sentiment,
Yeah.
I have to say. I mean, I agree with that passion, but yeah, I think, funding would be in jeopardy, licensures would be in jeopardy. Those are the kinds of things that would be a problem.
I can also say this is not an area that's essentially exists in a vacuum, and so there's already state laws and regulations that kind of cover it, so it'd be difficult for us to be able to introduce countervailing considerations through our own charter to be able to manage that when the state has already done a lot of work essentially in terms of licensing and controlling these statutes. And so it'd be very difficult for us to have those countervailing statutes, or I should say, parts of our charter, when the state's already covered that.
Unless we are independently financed.
That's a big part of it, yes, and the compliance issue as well.
Okay. Thank you.
Just to bring us back, the last two pieces to acknowledge with actually delivering services to youth. For one, when we say youth, what we are meaning, I learned that we need to define youth, child, and adolescent. And so when I say youth, I'm meaning kind of the full gambit. And so if you think about a 4-year-old and a 14-year-old being served within the same unit, those are really distinct needs. And there's ways with building design and staffing to accommodate that, but that's another layer of complexity. And there's, I believe, certainly different practices and policies and possibly some rule sets based on some of those age groups as well. And then lastly, kiddos are often, especially younger kiddos, are often accompanied. And so how do we physically accommodate for that and preserve safety as well, knowing there may be adults in the youth unit and those sorts of pieces. I had coffee with a community member probably 6 months ago, and that conversation is just so cemented in my mind of accommodating the full family. And when we think about like the conversations around pets and how could you possibly remove a pet from someone while they're in crisis, like how could you remove someone from their family while they're in crisis? So how do we construct a facility that's physically and crafted for that, but also licensed as such? These are some of the really hardy questions we're asking ourselves to do this well.
And yes, 4-year-olds will come in.
Okay.
May I ask a quick question? This is one of those hanging questions also. We have Looking Glass Services here in town. Broad, deep, long-lived, well-staffed, broad services. At some point, I'm going to ask the question, how does this weave in with what we're looking for the future? You don't need to talk about that right now, but that really is a hanging question.
Okay, so now talking about the maybe the most loaded topic that we've brought up yet, which is there's lots and lots of discussion over a voluntary treatment model. And is a voluntary treatment model the right model? So Marcus can speak to the legal aspects of that, and he will. What I will speak to is how the healthcare system is built differently from other systems, and why the healthcare system being voluntary is really essential in allowing us to do the work that we do. And so when I think about the systems that we have in place that are mandatory are primarily in the criminal justice system. And I think about how trust is built in the criminal justice system, which is that usually, not always, but usually, someone other than the person who is committing a crime calls the police. The police come and arrest the person who's committing the crime, or cite them, or do whatever else all of you do, because I'm not in your world, and address that problem. And they have built trust with the person who accessed the services, because that person who made the phone call has had the problem resolved, right? The goal is not necessarily to build trust with the person who's being arrested. Though I do think you all do an incredible job once they're in the jail and in parole and probation of doing that. But the initial community contact is different. In healthcare, it is not usually someone else who is calling for someone. Usually someone is accessing services themselves. And we have heard tremendous feedback through our survey. We also know as healthcare providers that if people access healthcare when they are in need, and we force them to do something they don't want to do, the next time they are in need, they are not going to access healthcare. And there are moments where someone is at the height of a crisis where we say, I really wish that we could force this person to do what they don't want to do. And yet when we want them to access healthcare services is before they get to that point. And it is without achieving that level of crisis. Part of the challenge is that we don't have enough healthcare in our community in order to prevent people from getting to that level of crisis. But the reason that we stay committed as healthcare providers to a model of voluntary care is about how we build trust. And that we will not be able to help as many people in our community if they believe that we are going to act in a way that is other than what they see as their best interest. So I think that is just an important, and I am happy to engage in more discussion on this. And I know that our public safety partners have thoughts and opinions about this as well. So really want to open it up, but this has felt like a topic that has just kind of been hovering over us in our design of the stabilization center model, and wanted to give voice to our reasoning and why we have that commitment, but also give the opportunity for discussion.
Wow, I want the transcript of what you just said. Well said. So, Sheriff Harold. Excuse me.
I can make a couple of comments. I know Brittany said she has a whole slide dedicated to, so I was sort of pausing for that. This whole conversation, and we've been talking about a stabilization center for a while, and I don't know if this is appropriate or not, but I'm sitting here thinking about when my teenage children have a really great idea and they share it, and then I tell them all the reasons why it's really more complicated than they think. And so I feel like the teenager in this scenario, when we first started on this, embarked on this and looked at the Arizona model and thought of, wouldn't it be great if they could go there instead of the jail, instead of the ED? And so just through naive, overly simplistic eyes, was super excited about it. And it's complicated, and I've learned a lot about the complications, and so I certainly recognize those. Still would love to see this resource in our community, and still would love to see it as a diversion from jail, obviously, and from the EDs. Still think that efforts towards having this sort of resource in our community are worthy, but much more complicated than when we first started having conversation. I will say that in order for this to be effective in diverting folks from jail, and I'll also say I recognize there's always going to be a need for jail. That will remain. But we've talked before about, and I've talked a lot about, when the police officer gets called to solve the problem, oftentimes they have two choices. They can do a police officer's hold and take someone to the emergency department if they think they're not capable of caring for themselves, danger to themselves or others. Or they can interpret the behavior they're observing and determine if it's a violation of a law, a trespassing law, perhaps, or disorderly conduct, and they can take that person from the jail. And I think you all have heard me say, currently, oftentimes the decision is jail, because if they make the civil decision, so police officers have this civil authority to do a police officer's hold to go to the emergency room, but oftentimes if they make that choice, they may very well see that person again later in their shift. And so they would more likely choose the jail option, because while they will probably see that person tomorrow, they probably won't see them still in their shift. And so these are some of the areas where when we have this resource in our community, we will need to work on some of those transitions. And so Brittany did a great job of talking about them within the building, from the chairs to a bed, back to the chairs. But then there's the next layer, which is the emergency room or the jail, and in and out. So, currently there are, and this is something I don't do, but have experienced it by taking people there, there is a mechanism by which in the emergency room, medical professionals can determine that it is not safe for this person to leave, even if they have changed their mind about wanting service. And so they can make a choice to keep that person behind a locked door. And I don't know what all goes into the decision-making process, but I know there's lots of rules about it. But they can do that in the emergency room. And without that, we don't want to build just another revolving door either. So it doesn't necessarily have to be within the facility, although when we first started talking about this, the Arizona model, it sounded like that was a possibility, that it could function that same way, and that all within one building is very attractive for my selfish purposes. But if not able to do that, then it's still an issue that we need to have more conversation about how we deal with it.
And Sheriff, you make a great point about civil commitment, that we will have the ability, provided the allowance is written into the regulatory requirements, which are not today. We will have the ability to do a director's custody within the stabilization center. That is what we are requesting of OHA. So that is to civilly commit someone and then transport them to a level of care where they can receive treatment. So for the individuals that today could be held in the emergency room, they would also be able to be held in the stabilization center for transport to the emergency room, or to the behavioral health unit, which is ultimately the place where they would receive treatment as they go through civil commitment proceedings. The difference also in the Arizona model is that Arizona does have a more permissive definition for civil commitment. So there are more people who can be held in Arizona. Lots and lots, and that conversation's happening at the state level today. It has been paused a little bit for our County Financial Assistance Agreement, CFAA, conversations that have been happening that have taken up a lot of the bandwidth, but we'll be starting again here. And Mr. Vehar has been on those meetings, so as he's talking about the regulatory environment, can speak more to that. I think also comparing Oregon to Arizona, our treatment facilities are dramatically less in terms of when you compare the need to treatment. So if we are to increase the number of people who qualify for civil commitment, today we have people who are unsafe, who are being discharged from a hospital environment because we do not have the resources to care for them, and they're being discharged often to the street because we do not have residential facilities to put them in. So do we turn on the spigot and try to add more people to a system, or do we invest first in building out the system so that we can provide the care that people deserve, is another question. Or I told you all this morning, I heard someone say we can walk and chew gum at the same time. So, maybe. I would love to see it. But Sheriff, did you have anything else you wanted to add?
I don't think so right now.
Okay.
Yeah, I just discreetly shifted the slides because we keep talking about what Marcus is going to share. So we want to pause for this, and then we will come back and have a more concentrated conversation around partnerships with law enforcement.
May I ask it, Captain Riley, is there anything you'd like to add from your perspective as the person who really is the front line?
I would just add to kind of what the sheriff said. I get the folks that come to jail, so a lot of the programs that we've started, we stabilize those folks, and then oftentimes I see them released, and within days they come back, oftentimes on a low-level crime, and they're right where they were prior to being stabilized in the jail. But for those of you that haven't been through the jail and saw, we've completely changed how we operate and the programs we have and the mental health and the treatment. And so we're seeing people get stabilized and they're doing well. And so if we had a place that didn't involve charges, court dates, all that sort of stuff to get people help, that would be really nice to have in our community. So we're seeing it's happening when you get someone in a stable environment and you get them potentially on medication in front of a psychiatrist with mental health specialists, that they're doing really, really well. But is jail the best place for people to do really, really well? And so if we built this, I think it'd really serve the community and really have people in the right lane. We talk about that all the time.
One piece I want to just add about the civil commitment aspect to this as well is that getting more facilities and more locations to be able to hold people prior to civil commitment is very, very helpful to the system at hand, mostly because there's a lot of significant limitations and regulations around where a person can be held and what happens with the person after the civil commitment occurs. So one thing I think to keep in mind with our jails as an example is that there are a lot of rules around how a person's supposed to be maintained on civil commitment if they were going to be held at the jail, and that requires things like an attendant that's specifically assigned to them, as well as a lot of other different regulatory aspects to it that we just are not usually seeing occur. And so for that reason, the more places we can have where a person can be appropriately held and treated during that hold period of time, the better it is for our system, the more flexibility allows for us to be able to treat more individuals and potentially see them committed with a path forward towards treatment. I wanted to talk a little bit more. I mean, so these slides essentially just a bit of talking points for me. And so ORS 430.627 really goes over the regulations that are required for a stabilization center, at least per the state legislature and what they've issued as well. Within that statute, there's also a carve-out that allows for the Oregon Health Authority to add in additional regulations on top of what I'll be explaining already that allows for them to be able to regulate what a stabilization center is supposed to look like. But one thing I think that's resonated throughout, hopefully through this presentation, is that it's only one piece of a greater system. You've seen, I think on one of the earlier slides, that crisis stabilization services is something that's referred to within statute. However, crisis stabilization services is not just what's performed at a crisis stabilization center. It really is supposed to cover a wide range of different issues, as you saw before with crisis lines and with mobile crisis units. Those are also aspects of crisis stabilization services. And a crisis stabilization center is just one of those aspects of how a county is able to perform some of those functions. And so what I want to discuss first and foremost is what does the state actually require for a crisis stabilization center? And I'm sure as I read through some of these requirements, you'll realize just how what we've done to actually meet these requirements really fits into what's best for the community and with a model that's more focused on treatment and care for the individual. And so first and foremost, it has to be designed to prevent or ameliorate a behavioral health crisis, to reduce acute symptoms of mental illness or substance abuse disorder for individuals who do not require inpatient treatment by providing continuous 24-hour observation and supervision is the first requirement. As we've discussed a little bit more in detail, this is not really a facility designed for inpatient care for long periods of time. We heard a bit earlier about Peace Health's behavioral health unit and what they're really designed to do. They're an acute care hospital. They're not really designed for long-term stays. Really what I've heard through litigation and through other means is that 14 days is really what they see as the limit of how long people should be there for. However, that's not really the reality of the situation, just with the backlog of how many individuals we have within the system and our inability to send them to the Oregon State Hospital or to other means really does limit our ability to transfer people out of that level of care to a more appropriate level of care if that level of care is higher than what Peace Health affords. Second, as a requirement, it has to be staffed 24 hours per day, 7 days a week, 365 days per year by a multidisciplinary team capable of meeting the needs of individuals in the community experiencing all levels of crisis. And that may include psychiatrists, psychiatric nurse practitioners, nurses, licensed or credentialed clinicians in the region, essentially where the Crisis Stabilization Center is located, which is important, as we'll discuss with triage, as well as what's mentioned in the statute, peers with lived experience similar to the experiences of the individuals served by the center. Now, again, those aren't all required necessarily. However, those are the individuals that really should be staffed there to be able to provide these services. I say it's not required because there's a may within the statute, so these are the kind of individuals who really should be there. But as we go through the rest of the criteria, you'll kind of see why those individuals are important to manage these. Those who will be showing up at the Crisis Stabilization Center. We have
Quick question, Marcus. You're talking about the rules. Are these specifically for Oregon, or does this go broader than Oregon?
This is specifically for Oregon. So this is within our own Oregon statutes, and again, the Oregon Health Authority is allowed to add in additional regulations on top of what I already described. But this, again, is state legislature what's required.
With the caveat that Director Gray provided earlier.
Yes, exactly. And so we also have to have a policy prohibiting rejecting patients brought in or referred by first responders and have the capacity at least 90% of the time to be able to accept all referrals. Again, as we've had multiple conversations within this team, the real goal is to have an open door policy and to allow for people who really need this care to be able to be here. And as we can see through statute, that's actually required to be able to, again, at least have a 90% acceptance rate for these individuals, because it really is meant to serve anyone who really shows up. We have to have services to address substance abuse crisis issues. We have to have the capacity to assess physical needs and provide needed care, and a procedure for transferring an individual, if necessary, to a setting that can meet the individual's physical health needs if the facility is unable to provide the level of care required. And so that's very important to consider with triage. And so we have individuals who will show up to the Crisis Stabilization Center, but may require a different level of physical need that the Crisis Stabilization Center is not really built to manage. And so as part of this system, they have to be able to bring a person to another facility to be able to have that need met. And as described in the previous slide before, that's why it's difficult when we see reduction of resources within the community, such as a reduction of an emergency department or behavioral health unit. That's essentially where the Crisis Stabilization Center can bring people to if they're needing a high level of care that can be afforded within that unit. So it's not just the Crisis Stabilization Center building to keep in mind too, it's really the community it's in, and its ability to be able to use those resources as well to be, say, self-maintained, to be able to provide the services that are required. We have to be able to offer walk-in and first responder drop-off options, which again is very important to consider when we're talking about people who are on the field and who have to decide whether or not they're going to be brought to jail or to the emergency department. This is another facility to which first responders can bring an individual to for initial assessment. They also have to be able to be screened for suicide risk and complete comprehensive suicide risk assessments, as well as planning for essentially their clinical need. And they also have to be able to screen for violence risk and complete more comprehensive violence risk assessments and planning when clinically indicated. So these are all different facets that, again, the state is required through statute that the Crisis Stabilization Center be able to meet. And that's exactly what we're talking to you about today in terms of how this facility is trying to be able to meet those goals and really what it is that this Crisis Stabilization Center does in the scope of all the rest of the other services that are being provided, whether it be mobile crisis or whether it be someone showing up at the emergency department. I do want to discuss a bit more about involuntary care and kind of what's required there. One thing I think that's very important to keep in mind when looking at the administrative rules, so I included OAR 309, which covers the Oregon Health Authority's behavioral science rules, or behavioral science department essentially, and kind of goes over to more of the rules that are related to behavioral health. When you're trying to care for an individual, psychiatric care is rarely ever seen as a necessary or required form of care for a person to be able to survive. I can tell you from doing civil commitments that psychiatric medications are not necessary medications as seen by the court and by the Court of Appeals for us to be able to say that a person needs to be in required treatment. And the Oregon administrative rules actually reflects a very similar thought pattern to where involuntary treatment is more based on a person's medical need and their need essentially for a significant procedure at that time versus a person who is in need of psychiatric treatment and who needs medications to be able to stabilize themselves, to be able to get to a point of better care. Again, those are not the individuals who the administrative rules are really designed to protect. And the civil commitment system itself does a very limited job in being able to manage those particular individuals as well too. Obviously, it's a very high threshold to bring someone through civil commitment, but just bringing a person into emergency room does not allow for them to require, again, that kind of necessary care. It only allows for them to be able to intervene when there's a significant medical issue that's associated. And again, that's also anchored in the administrative rules from the Oregon Health Authority in terms of when informed consent is necessary, which is very, very often in most situations. It's very, very rare that informed consent can be bypassed. And again, that's really only for significant procedures that are rarely ever seen to be mentally health related.
And I think just to speak about how this translates to practice, that someone who is an imminent risk to themselves or others, who is placed on civil commitment, can be confined in a healthcare facility. That person is still able to refuse treatment in almost all circumstances. And then when you look at someone who is under civil commitment who has been discharged from the hospital, the person is able to decline all services from us. So we have a statutory obligation to that individual who is under civil commitment, whom we have determined is unable to make good decisions, who is an imminent threat to themselves or others, but they are able to decline the services and the treatment that we are offering to them. So that's an important piece and distinction, that civil commitment, as it has been defined in our state and as and rulings that have been made on individuals who are under civil commitment, is not a pathway to involuntary treatment in most circumstances, limited exceptions. But anyway, just wanted to make sure that I was talking about how we see that play out in our civil commitment team.
This is just so many thoughts, but one is, these are some of the most extreme and extraordinary that we're talking about. Do you have any sense when we talk about the algorithm or the whatever word you use, Brittany, about determining what we thought the capacity needed to be for how much people would move through? What percentage of the total number of people we anticipate the model we've been working under will serve are, because we do this all the time, right? We start pitching things towards the highest acuity, most intense, most complex, most involved, but in terms of sheer numbers of who would be served by this facility, it's relatively small. Doesn't mean we don't need to figure these problems out, but just for some perspective.
Yeah, off the top of my head, I think it was 1 to 3%. That number comes from RI International, who provided us that algorithm, and they are from Arizona, doing this work a little differently than us, and I believe it's a great call out.
It's important to.
Yep.
And so going back to the administrative rules as well too, so when also looking under 309, again, that really does discuss a lot of what is allowed for involuntary treatment. And honestly, when a person is going to be fitting into such something such as psychiatric emergency care as well too, again, these are all different aspects of mental health treatment that are meant to fulfill separate roles that the Crisis Stabilization Center does not do in and of itself. Because something like psychiatric emergency care has to be done at an emergency room or at a hospital, essentially, at that level of care, versus this Crisis Stabilization Center, again, that has a very, very particular set of needs, very specific and needed needs for the community. However, it's not meant to essentially cover all of the bases for mental health treatment. It's meant to cover essentially those who show up. It's really meant to help stabilize. It's meant to help triage to different levels of care. But again, that does not create any ability for it to be able to provide involuntary treatment because, again, that's very specifically allowed within Oregon rules. And in those situations, it's very rarely ever medically based, or it's very rarely psychiatrically based. It's almost always medically based, as Eve had mentioned previously before. The last OAR I kind of included, which is the 415 scheme, that's just to kind of bring up the fact 415 is for addiction services. And so each different administrative rule section for the Oregon Health Authority is really covering a different criteria and essentially different licensure for different kinds of facilities. And again, while this Crisis Stabilization Center does bring up the fact that it needs to have some form of substance abuse crisis situations and be able to help stabilize them, there is a whole separate section of licensure and facilities that are meant for people who are suffering from addiction services, just like there's a whole separate licensure and systems bed for people who are suffering from mental health related crisis situations as well too. So again, this center we're looking at really does provide a very, very specific level of care, and the administrative rules have really designed different facilities and different locations to help manage those different levels of care that the Oregon Health Authority views are necessary. Again, whether those rules can be changed and how those can be changed, I think, is a very important topic for conversation, because expanding those rules and allowing for more overlap in how those systems work will allow for more flexibility within our community to be able to help better treat the individuals who show up there. Again, we want this to be far more open than it really is, because it's only offering very specific levels of care. And so again, I'm happy to answer any questions you have on involuntary treatment, but just know again, with how specific the administrative rules are, it oftentimes is based more on informed consent than it is our ability to treat those who show up and end up in our system.
Wow, well done.
Questions there?
And questions for Marcus? I'm trying to follow you on OARs and ORSs here, and I've got the numbers and I've got the links. So this is remarkable, the depth you're able to go into, Marcus. I'm looking forward to hearing more from you.
Yeah, and I'd be very happy to send you more specific citations in terms of kind of what I'm discussing. I just want to include, again, essentially generally what the schemes are. So again, 430 really covers mental illness under the state legislature, and then OAR 309 covers behavioral health related issues, essentially. That entire administrative scheme covers a whole set of issues from community outpatient to civil commitment to our psychiatric emergency services, and 415 is, again, all the addiction service related administrative rules that really covers the licensure of those facilities.
And it's pretty well tapped. I mean, you can move back and forth in there pretty easily.
Yeah.
That's brilliant. Any questions? Dr. Gray, back to you. Brittany?
Go ahead.
Yeah, so this is the promised slide and our last one to wrap up before we also invite ongoing organic discussion with you all. And just wanted to speak to some of what Sheriff Harold has already referenced with the context of what Marcus just educated us around, how we would anticipate thinking about the partnership and relationship with law enforcement, both in bringing folks to the stabilization center and also possibly transporting them away based on how they present. So we wanted to highlight the existing walk-in facilities, namely Hourglass. We haven't necessarily seen the full potential for how secure transport can be used if an individual is escalating and it appears that they need to be transferred to a higher level of care, namely the hospital. How we as the county can use director's custody, which gives permission to hold that person for the purpose of transporting, and then elicit secure transport, which we're still clarifying, and Marcus can chime in if I get it wrong, but I think we're still in conversation with OHA about logistics here, but that does not always need to be law enforcement performing that transportation. When someone is under a director's custody and moving to a hospital for a higher level of care due to their mental health escalating, their mental health crisis needs escalating. The distinction is if there are behaviors that risk violating a law, that we, best we can assess, which also, just as a caveat, a lot of this work is shared learnings from law enforcement learning about how to assess on the scene when and how to bring to us, and then for those of us at the Stabilization Center, assessing on site when and how to contact law enforcement in an appropriate way, and we get to teach each other. So there's going to be a learning curve there, but really with an understanding that we, out of best care and practice for the client first and foremost, and then also out of respect for the role that law enforcement does and doesn't play, how can we really utilize them only when appropriate, and create kind of procedures in place for that purpose. And then a lot of what's been shared too, kind of engaging that conversation within the framework of accountability, recognizing that there are individuals who have mental health diagnoses who also do commit crimes and need to be in jail. So how can we support that work while providing space for anyone and everyone who can be better served within the behavioral health system, and done so in partnership. This was also one of the slides that Pauline was going to speak to, so I'm doing my best, but I don't know if there's more for anyone else to weigh in on here.
I can also stall a little bit too as well.
She may not be coming back, that's okay.
Mostly just to say, first off, you're exactly right in terms of secure transport. It doesn't have to be done only by law enforcement. It can be done by other licensed entities as well too. And so also just to kind of give more context of what a director's custody really looks like, it has to be an assessment of the individual as they are currently presenting and whether or not they're a person who, potentially due to a mental illness, is either dangerous to themselves or others, or they're unable to provide for their own basic needs for whatever reason. But one thing to really keep in mind in those conversations is you're looking at how the person is currently presenting. You're not looking at the context of the person's history. So while there may be some considerations later on about a person's criminal history and their past and what's been done before, really those assessments are meant to be contemporaneous for what the person sees. So it's very difficult for us to be able to say that those director's custodies can really cover all levels of dangerousness for an individual. It's a very, very nuanced take that the person has to have when deciding whether or not to put someone on a director's custody. But when that decision does get made and they're transported, it doesn't automatically initiate an extended hold. They're typically brought to a hospital or another facility to be further assessed if that hold should be continued on. So again, it's difficult sometimes when there's repeat offenders or people who we find out later on have rich criminal histories to say that, well, why didn't we think they were dangerous at the time? It's a very, very nuanced discussion about how the person's currently presenting outside of any other facts.
And Marcus stalled long enough for me to think of one more thing, so thank you for that, and that was really helpful. So just to know, and in light of speaking to voluntary or involuntary, I do want to highlight what we are trying to tease out is if we determine somebody does need to be transported to a higher level of care, the existing resources that we have with the hospital that we are not trying to replicate, we do need to keep that individual and the staff safe until secure transport arrives. And really, like, narrowing in on what could be, I don't even know an appropriate time to guess at that, but 20 minutes or 2 hours or what have you. So that's the granular level of conversation that we're having with Oregon Health Authority right now. That does include language like holds, which is to ensure safety for that person until they can be transported to the proper level of care. So I want to point that out because I don't want folks to hear us saying we're only providing voluntary treatment, and think that if somebody indicates that they need a higher level of care, that we'll just let them walk at that point, or that that's an immediate call to law enforcement. Those are the nuances that we're working through right now within the framework of existing licensure. Yeah.
One thing I could add with all the work that the consultant group did, one thing I learned with the Arizona model is their stabilization center has numerous back-end supports off that system that makes theirs work. They've got the supportive housing, so people are typically there for a short period of time and they're on to the next step. And so that's, as I hear you guys talk a lot about like supportive housing and just housing in general, Arizona has those models to help people and keep them out of the criminal justice system with the back-end supports. So they've been at it for like 30 years down there too, so they got a head start on us.
A system, which is incredible, and honestly, I mean, Marcus, when you talk about accepting 90% of individuals who arrive, I think about how difficult it is to discharge. And this is true pretty much everywhere because of the lack of a system that we have available to us. So the stabilization center, as we've mentioned, is not the end-all and be-all. It is one more tool in the toolbox that we need, and we still need to build out the remainder of that system. And Sheriff or Director, oh, go ahead, Commissioner Buck.
And just a question off of what you just said, if you need to be able to accept at any given point in time 90% and you're full, how do you continuously meet that mark?
Yeah, I mean, we will have to create procedures for a model to divert. And it would probably be diverting to the emergency room. And of course, we know that emergency rooms in our area are frequently on divert. And they are also supposed to accept everyone who arrives. And then when everyone's on divert, no one's on divert, and everyone just takes turns dropping somebody off at the facility, and you have procedures for overflow. So none of that is good, right? And we are seeing this everywhere in our healthcare system, that we don't have the resources, we don't have the staffing, and we are unable to adequately meet the community's needs.
Well, I think across the board, we face capacity issues, whether it be in the jail or whether it be in the simplest of medical facilities. And by adding a crisis stabilization center, we'll face capacity issues immediately. I mean, there's no question about it. And I think Captain Riley can talk about what do we do with capacity issues on a daily basis in the jail. And I wonder if either Sheriff or Captain Riley, if you have anything you need to add at this point in time.
I can just share a little bit, and we got to meet with folks over in Deschutes County. So we met separately with the Sheriff's Office, and then we met with Bend Police leadership about their stabilization center, and they're definitely glad they have it. At the time, we were still talking about a model that was more robust, and they thought that was attractive also, but they were happy that they had something, and they have something that we don't yet have. With respect to the transportation, separate from these conversations, the board, we've had conversations about the Deschutes County funding. They have that too. And so one of the agreements they made when they built the stabilization center, if the Bend Police Department or the Redmond Police Department takes an individual to the stabilization center who's then recognized by the professionals working at the stabilization center that they really ought to be on a director's hold over to St. Charles Medical Center, they make a phone call to the Deschutes County Sheriff and they send somebody over to do that transport. So that model works well because the Deschutes County Sheriff has staffing to provide that transport. And then that person is transported over to the hospital, for those follow-up services. So that's this transport conversation we were just having, is figuring out how do we accomplish that same thing within our structures. So we're headed in the right directions there, I think. Although, of course, we have the funding concern for both the stabilization center and all the services that go around it. The other thing is just, I was recently on a jail tour, as I do from time to time, and there's an individual up, he was at the time on the 3rd floor of our facility in our wellness program, out in a day room, sort of wandering around, but comfortable and doing fine, doing great. And it's an individual that I read his name on our blotter at least once a week, typically. Because he's booked in and typically in crisis, and so his behavior and our interaction with him usually warrant a note in the briefing that the jail sends out. This individual's back in custody, and here's how it went when he came back in custody. And so it's remarkable that he's up on the 3rd floor, out in a day room with a bunch of folks, not engaging in staff altercations. I mean, it was super exciting to see him walk into the day room and know who he was and that he's doing so well. He was there on a municipal court hold, as he almost always is, so limited time. And so we get to see him doing great on the 3rd floor, and then he gets discharged because it's a very low-level misdemeanor. And then he gets booked back in, back in crisis. And so the idea of these supports, like Clint just mentioned, wouldn't it be great if he was, one, maybe stabilized in a different facility, not ours. But even if he is getting stabilized in ours, let's say because of his crisis behavior, he's not appropriate for the stabilization center. So maybe we still go through that really hard bookend process that we do all the time now. But maybe a couple of days down the road, he could be moved from our facility into the stabilization center. And then maybe he doesn't have a clock because it was only a misdemeanor lodging. Instead, he's in a facility until there's an opportunity for him to step down and interrupt the cycle. So just wanted to end with a little bit of positivity. Like, we're still working towards something that would just be phenomenal for our community. There's a lot of unknowns, but thinking about the difference it would make in, you know, in that individual's life and whoever that individual still has as family support, and I don't know that that individual has any still sticking in there with him or not. But those sorts of downstream impacts could be pretty phenomenal, so.
At which point Brittany's dream comes in, and what I wrote is that ideally, the connection is either on their own or to a loved one or to an Uber, he said. Whether taking, whether
Or Oregon
taking to a stable place.
We're agnostic.
Or to their probation officer. For the 2,300 individuals that are on supervision, this fits in very nicely. And in most cases, particularly with the mental health unit, their parole officer is often their advocate and has gone with them to appointments, has checked in, has provided that transportation. So we can have that engagement. Now, it's granted it's for a smaller chunk of the population, but it's a significant chunk of the population. And we can have that engagement, not only in terms of transportation, but we will know the conditions of their supervision, which might actually lead to treatment options that are available to them. And they can also just provide the calming presence and some of the safety elements there that doesn't take a law enforcement officer off the street. Our folks can do that. We're actually entering into a contract with Springfield Municipal Court to start doing some misdemeanor supervision work just for this. So we're excited about what we can be doing. It's early on in our process, and of course the mental health unit is about 15 minutes old, so we're still learning about its capacity and how we can move forward with that. But it's another tool in the toolbox, and I think another positive here towards the end of the meeting.
And Greg, as you mentioned, the parole and probation, particularly the newer positions, are performing services that have never been performed by a parole and probation before. The first would be cut, should we cut services? But we'd like to end on a note of optimism today. Commissioner Buck.
Thank you. Given the regulatory requirements that have been presented for youth versus adults, however that's defined, and trying to get something going, and knowing that youth has such a high demand and impact in the community, is there any way to provide something for youth first, separate, prior to the full meal deal? And is that practical? Is that possible given the regulatory requirement we're in, or do we still need to?
Commissioner Buck, I'm sorry to interrupt, but your mic seems to be not working. Can you?
I was given one instruction before we started, and that's remind people to move the mic in front of them. I failed. I'm sorry.
So is there a possibility to separate and begin with a youth facility prior to what I call the full meal deal of youth and adults, knowing that there's a scale of economy that works to make that happen, financially speaking, but the regulatory requirement, it seems to be in flux potentially, or do we have to change that regulatory requirement to even have one piece of a stabilization center? Do we have to just recreate everything?
So we're going to be having this conversation more here in a few weeks. There are possibilities for parsing this out and starting with one program or another. What we lose by doing that is the full model. And so we have to think about, with whatever options we may be looking at, what need is that able to serve? is that a stabilization center, or is it one of the many other dramatically needed resources in our community, whether it be residential facilities or inpatient facilities or what have you? And if we are investing with stabilization center dollars, are we wanting to invest in a stabilization center and model, or are we wanting to fill a gap somewhere else with residential services, for example? I think another important question is if we invest in youth, and Dr. Ritu can speak to this way better than I can, but the emergent need in our community is for the youth who are sitting in the emergency department. And so anything that we invest in earlier for youth, we need to be able to take that high level of individuals in crisis. And at this point, we're not sure that we have options available to us to be able to do that. Part of that is a regulatory burden. So we're engaging in more conversation with stakeholders, and we'll have much more of this discussion as we are talking about the awarding for the providers of the stabilization center. So more to come.
I look forward to that conversation, because it just seems like for most things, if you start and break the cycle when people are younger, you'll be able to create less flow into a larger system. But I know that, again, as we heard, it's complex. It's just that I heard that urgency come from you and kind of grasped on that.
If I also may add just one thing from a previous discussion before about the 90% acceptance rate when it comes to the Crisis Stabilization Center, I do want to clarify that do we have to have a policy in terms of not rejecting people who are brought in or referred to by first responders? And then 90% capacity is more aligned with those referrals that are coming in versus just anyone who walks into the door. So there obviously does need to be walk-ins as a part of the requirements for them to be able to just come up and be accepted. However, I think a lot of education would be necessary to make sure that our community partners understand who really should be brought to the Crisis Stabilization Center, because those referrals are really what we're supposed to be accepting on a pretty regular basis, again, at a 90% acceptance rate. And so it's not total capacity, it's more so those who are brought in by those by those first responders, I should say.
So on to this last slide, I want to paint a little bit of a future forward-looking picture. And I want to recognize the danger in this because, so I've been doing this reading, I'm going to get all academic on all of you. I've been doing a reading on complexity theory and complex adaptive systems and managing those. And one of the things that the theory talks about is how good experts are at explaining what has happened in the past and how bad we are at predicting what will happen in the future. Because you can't predict what's going to change in the system that then will change your path. And I relate that because we have had a change in our system of late. And that has been the closure of an emergency department, or the impending closure of an emergency department that provides most of the psychiatric emergency services in our community, and a lack of stability in terms of our expectations around the future for inpatient behavioral health in our community. You know, what I will say, I'll say this now and I'll say it next week when I talk to you about this more in terms of the update on University District. PeaceHealth is a good partner. And they, you know, they're a great member of our community, of our business community. There's nothing about any of this. There's no bad actors. And we all like to think about, you know, there's got to be a bad actor when something bad is happening. But the reality is that we are all under tremendous pressure for a variety of reasons. But in looking at the changes to our behavioral health system in our community, it also presents a potential opportunity for us to think about what does the future look like that could be different from what we were envisioning. So PeaceHealth very much would like to close the facility that they have on the campus that they are on right now. They have no interest in inpatient behavioral health services leaving our community. There are some financial realities associated with being able to maintain inpatient behavioral health services in our community. But if we are looking at a model of what do we need for inpatient capacity, really what we need is a different facility at a different location. And who runs that and who's involved in that and how that all operates is yet to be figured out. But one of the opportunities that we took as a team when we were thinking about this change that was occurring is going back to looking at the Arizona model. The Arizona model, the RA International was consulting on, the reason that it is a no wrong door facility is that the inpatient behavioral health unit is on site with the stabilization center, the 23-hour recliners, with the residential facility. It's all there. And so you never have to worry about these transport issues of, am I allowed to put someone on a hold, and how long can I hold them, and who's allowed to transport them, and how many hours can I have them before I need to call, you know, all of these things. If you have everything on site, then you have what you need. And I think this is it's an interesting thing for us to consider as we think about the fact that a new inpatient facility is necessary in our community. And I say this with reticence because I already know what an uphill battle we are facing from capital construction and operational deficits with the facility we're envisioning. And inpatient behavioral health does not operate better financially than does the stabilization center model. It's all runs at a deficit. But I do think that it is something for us to consider as and what partnerships might look like in that regard to be creating the full system in one place. So anyway, that's one more thing that I would leave you with.
Well, that's a wonderful vision. And, you know, I would channel Commissioner Sorensen at this point and say, if you had no restrictions, what would it look like? And, you know, that's a common question. Remember that Steve McCrisey asks that question all the time. So what's your answer? No.
Well,
that's, you know, that really is the, what would it look like? And let's take the restrictions away and you know, put everybody's head together. What would it look like?
Dr. Ritchie.
I've been to Pima. Oh, I'm sorry, Doctor.
No,
Please.
I was just going to comment on the time issue because I really feel this urgency, like a lot of people do. But I also want to balance this with the idea that I think we really want to try to get this right the first time. Because this center will develop a reputation quickly, you know, just like a new restaurant. And people will talk about it, and people will make decisions about whether you can get good care and whether it feels safe and whether it's welcoming. And then they will base their treatment decisions on that in the future. So I struggle with this balance between wanting to get anything up, but at the same time wanting something that we can really be proud of and that will make people trust us and come back.
Yeah, I really appreciate that because I think it's important that we hold that value of delivering quality services that the community needs. And balancing that with the urgency, the sort of being aspirational about all the things we need, but being pragmatic about what we can actually do with the urgency. And I completely agree with you. We don't want to rush it at the expense of quality service, but nor do we want to delay it. We don't want to sacrifice the good on the altar of the perfect in terms of scope of services provided or location, which is all very different than quality. I think quality has to be at the top of the list. And I think when we get into I really am so grateful to Director Gray for really just putting it out there about the tension of the voluntary hold versus involuntary, because we've sort of set ourselves up to ask that, and it's the wrong question. We shouldn't be saying, which are we going to do? We should be understanding we need both. And so how are we going to do that? And getting it right the first time, yes, but I would say getting the first one right Because my understanding from the very beginnings of these conversations several years ago, when I first came on the board, is that we need several of these, actually. And Dr. Gishoи talked about the urgent care for the mind concept. You need more than one urgent care in a community, a population and geography of Lane County. And we'll never get the second, third, and fourth one if we don't get the first one. So focusing on getting that first one, and then that will, we have the biggest gap now, which is nothing. We'll get the first one, and then we'll still have some gaps, and then we'll work to fill those gaps. I don't really have a conclusion to that, but those are some of the thoughts that were, as I was listening to all the different pieces of this conversation. And I think Captain Riley talking about how, yes, we kind of stabilize people, but the difference with the jail is it's not set up as part of a coordinated care model where there's a warm handoff and case coordination after a person leaves. When they leave your custody, they're out there, and they might come back within hours or days, or they might not. And that's the critical difference. That's why it's not actually a stabilization center in this model either. So this just, for me, this has just been really grounding and helpful, and both it's more daunting than ever, but also feels more within reach than ever, because I think we're having the right conversation now, and that's due to our administrator kicking it off by saying, let's not get so stuck in the logistics of a location and a size and a budget, but let's really talk about what we're trying to accomplish and who's going to be served. And so the last thing I'll say is just reminding us that we always want to talk about those most acute, likely headline cases, but that is actually in terms of number of people, of constituents of this county that a facility will serve, is very small. And so we sort of owe it to the community and to ourselves to get something up and running to serve that large number of people in spite of that small number that are such a great challenge.
Well, thank you for that note of optimism. And you said you don't know where your conclusion is. I think Dr. Ratu's analogy to a restaurant, you know, the first meal we serve has got to be a pretty darn good meal. With that, I've never seen, to me, what's really particularly encouraging is seeing all these people sitting at this table. And this is not the first conversation we've had today even. You know, you've been talking together already today in ways that I've never seen happen before at the critical intersection of behavioral health and the criminal justice system and the community. So with that, if there's nothing else, on that wonderfully optimistic note, we can end this meeting early. Any objections? Hearing none. Oh.
Trying to set up conversations with our RFP applicants that need to happen before we can have that board meeting. So next 3 to 4 weeks would be my intent.
Before the end of the year.
Before the end of the year, yes.
Thank you, everybody. Marcus, thank you so much once again. We are adjourned.